multiple Zooms as everybody's still dealing with that. But thank you everybody again for attending another Pepper Center rounds where we actually get to bring on board other faculty and Pepper scholars from other Pepper Centers across the nation. So we're really excited today to have with us Dr. Maria Loizos, who is a clinical neuropsychologist and assistant professor within the Department of Psychiatry and the Alzheimer's Disease Research Center at the Icahn School of Medicine at Mount Sinai. And she did her training at both Northwell Health and also did her PhD in clinical psych and neuropsych at Yeshiva. And a lot of her work today that she's going to be presenting from a T32 that she's a fellow for at Sinai is on, as you can see, older adults and vulnerable populations research training program. Her research is on this digital literacy and technology use in diverse older adult populations. So we're really excited about this because we do have a lot of interest right now on MCI and primary care management of older adults with multiple chronic conditions that include that, as well as other dementias. So Maria, take it away.
Thank you so much for having me. Again, my name is Dr. Maria Loizos. I'm an assistant professor in the Department of Psychiatry at the Icahn School of Medicine at Mount Sinai. And I am so pleased to be able to speak to you about my Pepper pilot study, developing training for MyChart use for older persons with mild cognitive impairment. So I think it's important before we kind of dive into the Pepper project, I wanted to just kind of provide just a brief introduction to who I am, as well as the work that kind of led me to this point, as well as sneak in a picture of my dog. My trajectory is probably not uncommon. However, I don't know that it's the typical trajectory of a researcher, and I could be totally wrong about that. But as you heard, I'm a trained clinical neuropsychologist, meaning I am a licensed clinical psychologist and I have specialized training in brain behavior relationships, and more specifically, my work has focused on older adult cognition and the changes that they can experience as they get older. Primarily, I do a lot of work with older adults who worry they may have dementia. So I perform a lot of assessments in order to kind of differentiate between normal aging and abnormal cognitive decline. I also provide training for our adult neuropsychology program, which is dedicated to training up-and-coming neuropsychologists. And if you had asked me when I was in graduate school and when I was in practicum training, I always thought that I was going to be a neuropsychologist working clinically, and research was not an option in my mind at all. Until during my postdoctoral fellowship at Mount Sinai, I started doing a little bit of work with my mentor, Dr. Mary Sano, who's the director of the Alzheimer's Disease Research Center. I have always understood the utility of research. I came from a PhD program that, really emphasized the importance. But it was during this time on my fellowship where I could see the value it could add to older adult patient lives, and that research we were conducting was having a direct impact on patients. For some patients, their only treatment options were to engage in research. So following the completion of my fellowship, as everyone does, I was looking for jobs, and I was hired as faculty at the ADRC. And then in an attempt to increase my research skills, because I was kind of going into this brand new, I was accepted as a T32 Fellow in their older adults and vulnerable populations program. And slowly, as I started to develop my research skills, I also started to discover and establish my research interests. At that exact same time, the pandemic happened, and we were in the epicenter, and we had to kind of navigate this brand new research landscape. The way that we had become accustomed to conducting research at that point needed to change quickly. Our center conducted cognitive evaluations in person, clinical trials in person, as well as imaging trials and studies in person. And it was especially difficult at the ADRC because our participant population is older adults, and older adults with comorbidities, and often more than one comorbidity, and older adults with cognitive decline who may not remember the importance of social distancing or wearing a mask, making this group highly vulnerable to COVID. And we had to find a way to continue the advancement of research, provide services for participants, but also do so in a way that was safe for not only our participants, but our staff as well. So kind of really trying to find this balance of, continuing research, but making sure we're maintaining safety as well. To accomplish this, we transitioned our cognitive evaluations from an in-person format to completely remote. And in this process, we learned a lot, and we documented it in this research article that you can see here, and that was published, I think, early last year. For one, we are all very fortunate and capable, and we're all sitting together here on Zoom, despite all of us kind of being in different locations. And we all probably made the transition to Zoom fairly easily. I mean, probably with some hiccups, but for the most part, fairly easily. And when the pandemic started, we were able to kind of just make that transition fairly easily. However, you can't expect the same level of adaptability from older adults, especially older adults with cognitive decline. We had to find a method to assess patient cognition in a way that wouldn't be burdensome or taxing, and in a way that wouldn't limit participants who had declines or alienate participants who didn't have access to technology. I mean, the assumption that everybody has internet or technological access isn't true, and underrepresented populations don't have that same access. So we decided to conduct our evaluations over the phone. However, this idea that older adults have difficulty with technology started to really pique my interest, because how many things in an older adult's life are they really missing out on because they don't have that same access, or that that capability to use the technology that the rest of us have. As I started to gain this interest in improving older adult technology use, I wanted to get more of an understanding of participants' feelings and attitudes towards technology use. And so I decided to hold a focus group with a group of caregivers of our ADRC participants. So it's a weekly support group that we have. And in this focus group, I wanted to gain an understanding of what technology, if any, participants had, how they used it, and more specifically, how they felt about using technology for telehealth, since at that time, we were in, and I guess technically we still are, in the pandemic. Now, on the next slide, I'll kind of review what I learned from that group. However, what made this group so interesting was that this group was held exclusively over the phone. Although the facilitator of the group, one of our fabulous ADRC social workers, tried to really steer the group to meet over Zoom, the group was hesitant and, I mean, resistant. Really, they didn't want to do it. They really depended so much on that group, especially during the pandemic, where they felt so isolated and burnt out caring for their loved one. They were worried that something would go wrong and the group wouldn't function the same. And in this poster that I have up on the screen, we described their transition from telephone to Zoom. So interestingly, what happened was one day last year, something happened. All of the telephone services on the East Coast went down for the day, and on the day that they were supposed to meet, essentially forcing them to join Zoom. And although there were some hiccups, they all successfully logged on and had their first Zoom meeting. So they described it as kind of the next logical step after being on the phone for so long. And they reported kind of really appreciating how the connectedness improved after hearing everyone's voices for so long. And now they could see their faces. And to this day, they continue to hold the support group over Zoom. So it was kind of a little success story there. Now, to kind of go backwards a little bit, the focus group that I held with the support group As a reminder, this is a group of caregivers who are taking care of their loved ones with cognitive decline. Most of the group, if not all of the group, had some form of technology, whether that be a smartphone, a computer, or a tablet. And the way they utilized technology varied from some watched television shows, or, they were on YouTube, they were playing games or looking up recipes. I had one participant who used their technology to help them meditate, since the pandemic was a stressful time for them. Some participants engaged in telehealth visits with their technology. So some found it really easy and helpful. They were able to download whatever app the hospital designated for telehealth and use it with no issues. And during that time, early in the pandemic, we hadn't even really, everything happened so quickly. So we hadn't really sorted out which app we were using or what system. And they were really flexible and kind of able to adapt quite easily. Other participants found telehealth difficult. It was cumbersome. Some patients reported they had neurology visits in which they had to somehow show the doctor their loved one's gait. And so they just found it kind of really difficult and not really helpful or consistent with what a typical appointment would be in person. Then I transitioned the conversation to how they utilize technology to manage their own health. So up until this point, we're kind of just talking about technology in general, and they all framed it based on how they used it to kind of help their who they were caring for. But I wanted to kind of know about how they used it for themselves. And this is where a lot of frustration was expressed. So although they acknowledged that there were ways technology could be helpful in their own health, managing their weight, for example. There were a lot of feelings of technology was just another thing that they had to manage, and they wished it were easier, but also they acknowledged that this is the direction that society was kind of heading in. So although they had these frustrations, they kind of were like, well, I guess we have to use it anyway. Following this conversation with our caregiver focus group, I was wondering what the enrollment in telehealth looked like for our hospital. At Mount Sinai, patients can utilize an electronic personal health record portal. It's called MyChart. You guys may have something different, and it's linked to their medical record in the hospital. So we utilize Epic as a medical record service, and it links directly to MyChart. And the way that they enroll in MyChart is following a visit, a patient is handed a piece of paper with a link or a code on it, and it kind of gives them these directions to go to mychart.com and utilize this link to kind of affiliate themselves with their medical record. And then they're kind of in this portal and they have access to their medical records. As you can see, during this period earlier in the pandemic, what we're looking at are patients who were offered MyChart, and this is in our Department of Internal Medicine. We're looking at patients who were offered MyChart and then those who were enrolled versus who did not enroll. And then we decided to kind of look at the data separated by age, so that 18 to 64-year-olds are on the left side and older than 65 years of age are on the right side. And what we see is that there is this drop off of patients enrolling in MyChart, starting at age 64, even honestly 62 years of age. And this data, coupled with feedback I had received from our own ADRC while we were transitioning, as well as feedback from the focus group that I held, is really what kind of pushed me to develop my PEPPER project and try to determine a way that we could improve MyChart usage in this older adult population. Okay, now just to kind of give some background before getting into the details of the project itself, developments in computer and information technology has occurred at an unprecedented rate. I think, what was it, like 2006, we had the first iPhone, and now we have, what is it, iPhone 13. Things are moving at a fast pace, they're happening rapidly, and it's definitely amplified by the fact that companies are always trying to compete with each other to put out like the next big thing, right? So things are constantly coming out, things are constantly improving. There's always a new way to do something. Cars have changed. Now you don't even need a key. Like, just things are changing all the time. And technology has become part of our everyday life. I mean, for work purposes here, again, like here we are all on Zoom, we were able to kind of transition some of us to a work from home model. Education, more students are taking classes online than ever before. Entertainment, whether it's television shows, Hulu, Netflix, even our healthcare is transitioning to, not even transitioning, but utilizing more technology every day. And in fact, 90% of Americans reported using the internet in some form or another. Now, at the same time that we're having this kind of accelerated growth in technology, the population is aging, and they're getting older. As kind of boomers all kind of grew up, they're all aging together as well. So we have kind of this large group of people that are kind of getting older. In 2013, people over the age of 65 accounted for 13% of the population. And by 2030, that number is expected to increase to about 20% of the population. And this isn't just exclusive to those over the age of 65. We're also seeing this increase in population in our oldest olds. So those over the age of 85 accounted for 4 million in 2000 and is projected to increase to 21 million by 2050. So we have this really large population as well as this accelerated growth in technology, and they kind of don't always match up or go together. Technology can be great. It can be used to kind of improve the quality of life, but older adults are at a disadvantage. Technology can improve and foster functional activities of daily living. As a neuropsychologist, when I see patients clinically, that's a huge aspect of kind of what we're assessing. Can a patient function day to day independently? And some patients, as they get older, have difficulty managing these things, but they can utilize technology in a way that could be really beneficial. For example, utilizing a timer on their phone or a reminder to kind of take their medications, or setting up their bills to be on autopay so they're not messing up any bills or forgetting or overpaying, et cetera. These challenges with technology are more evident for those that have mild cognitive impairment, because depending on where the impairment is, they're going to have difficulty kind of with novel problem solving or kind of utilizing the technology in a way that maybe we take for granted. There is, that being said, there is an increasing number of patients who are utilizing technology to promote a healthy lifestyle. From things like MyFitnessPal to track, what we're eating, the health app on our phone, how many steps that we take. They even have pulse ox monitors on our phones now. And telehealth services, text messaging, email, kind of all of these things are being used to facilitate kind of a healthier way of life. Kind of as part of that, or along that vein, electronic personal health records, or PHR, allow for patients to receive the most up-to-date information about a patient's healthcare, as well as have more control of their healthcare in general. They kind of get up-to-date information as soon as an appointment's over. They can see the note, they can see what results happened from certain tests, they can see what appointments are upcoming. It kind of really allows them to have more control in their health. And like I mentioned earlier at Sinai, we have, we utilize MyChart as a PHR, which is linked to Epic. Now, we kind of got a taste of this when I showed that data earlier, but older adults, and especially those with mild cognitive impairment, overwhelmingly underutilize PHR. And the problem is that rapidly changing technology does not allow for patients' ease of use. As soon as they kind of get accustomed to one thing, a new thing comes up and it kind of makes it more difficult. And if you have someone who has cognitive decline and novel problem solving is, not something that they're familiar with or they have difficulty with, they're not going to be able to figure out the technology as easily. So there really exists, there really exists a need to assist older people with mild cognitive impairment with utilizing their personal health records to manage their health and maintain their independence. Because as we know, what will facilitate an older adult's health to kind of maintain or, be as healthy as possible is having them be as independent as possible, but as safely as possible. So this kind of led to this thinking of, can we develop a training module which utilizes feedback from patients and caregivers to help them utilize MyChart? So during the pandemic, there was this massive shift to telemedicine, during the COVID pandemic. And the use of personal health records has definitely increased. Again, it kind of allows for up-to-date info on health. You can manage your medical appointments. You can contact providers if you have questions. You don't have to call an office and kind of wait for someone to call you back. You can send a message and quite easily. I know a lot of the physicians find that easier than having to return a phone call. Kind of requesting prescription refills are much more easy. And patients who have utilized personal health records report positive effects because there is a benefit to having patients feel like they're in control of their own health, right? They're kind of in the driver's seat. They're not taking a passive role, they're taking an active role in their health. And it can lead to decreased healthcare utilization and improvement of chronic diseases. And this could be a real major benefit to older adult lives. However, as we've kind of discussed, personal health records that technology is not developed with older adults in mind. Whenever a developer is putting out a piece of technology, they're really thinking about what group is going to use it the most, because that's where they're going to make the most money, right? And so they're not thinking about older adults when they're developing this technology, because it really involves kind of having this understanding of older adult needs, preferences, and abilities that are just so much different than kind of younger people, younger adults. Their abilities are very different. So we have to kind of keep that in mind when we're developing technology. There's also kind of this thought, I think, that older adults are not open to using technology, but research has kind of shown the opposite. They are quite open to using technology. But there is a caveat to that. There needs to be this positive initial experience to the technology combined with an interactive teaching modality, and that can encourage continued use. So that being said, kind of all of this, kind of my background, kind of all of, the background of technology usage and kind of aging led me to develop this PEPPER pilot project. And so these are my specific aims. The first is understand the nature of user difficulties and kind of their knowledge needs regarding MyChart use, and determine preferred training method for older adults with MCI and their caregivers, both with and without MyChart experience. So I was really interested in kind of understanding not only what keeps someone from using MyChart, but of those that do use MyChart, what makes it difficult? Is there anything in there that kind of isn't user-friendly? And utilizing their feedback to develop a training module. So that's aim 2. And then finally with aim 3, kind of to assess the feasibility of providing training to improve the use of MyChart amongst older adults with mild cognitive impairment. Okay. So for this study, I will be recruiting participants over the age of 65 diagnosed with mild cognitive impairment. We are assessing mild cognitive impairment utilizing the Peterson criteria, which specifies that a patient must have kind of one cognitive domain that is below normal. They are functioning day-to-day independently, a normal cognitive screen, as well as a subjective cognitive complaint. And so at the Alzheimer's Disease Research Center, we have a longitudinal cognitive evaluation that categorizes, or not categorizes, but diagnoses patients as either mild cognitive impairment, dementia, or normal control. So we kind of have these patients that are already kind of diagnosed with MCI, as well as the kind of the surrounding geriatric centers that we work with all the time. When they refer patients, they refer them based on diagnosis. So we have kind of this wealth, this large population that we can pull from. And as I mentioned earlier, my goal here is to understand the difficulties that these participants are having. And what is important is to understand not only the difficulties of those that are using MyChart, but also understand what's keeping this group of older adults from trying to use it. Is it just that nobody's told them about it? Again, we're depending on kind of, when they go to a visit, a nurse or an assistant is giving them this piece of paper that has this code on it. Is that the best way? I mean, are they able to kind of follow those instructions? Is that kind of confusing already? Is that already too overwhelming? Let's say they've made it past this first step. What about the interface of MyChart is difficult? Are things easy to find? I use MyChart as a patient, like as me myself as a patient have used MyChart. And there isn't even an option when you're logged in to get help if you need it, or if you need some sort of assistance. If you're having some sort of trouble, there is no help option. So I could understand how it could be difficult for someone who doesn't really have any experience with technology or kind of utilizing any of these portals. I could see how it's hard to navigate and use it. So to get at these issues, I plan on holding focus groups with both users and non-users of MyChart. Participants will be encouraged to be candid about their troubles, the troubles that they're having. Obviously, some changes are going to be out of our hands. I can't redevelop the program or code it. But if we can get specific about the issues, we can utilize the participants' language in the training module itself. And I think that's really important, is kind of emphasizing the importance of utilizing a patient's own language. The way that we talk about technology, the way that we use it, and we talk to each other about it, is very different than the way older adults talk about technology. A cursor, not everyone knows what a cursor is. They call it a pointer. Utilizing the language, the way that they define items on the screen is going to be really important when we're talking about developing a training module. Regarding the training module, I'm also hoping to get an understanding of how patients or how participants want to learn. Do they want someone in real life helping them? Do they want that person to look like them? So someone that's their age. Would it make them feel comfortable to have someone their age? If it's someone younger, do they feel comfortable asking questions? Do they want a manual? Do they want a video? Do they want a combination of both things, right? So I think it's going to be important to kind of assess what their learning preferences are, in addition to what that learning module looks like. So following the focus groups, the training module is going to be developed. And as I mentioned earlier, it's kind of unclear what the training module is going to look like. However, my hypothesis is that older adults will be able to identify what makes it difficult for them to use MyChart, and that they can inform a training module to improve the utilization. At the ADRC, we have experience with this method. We've held focus groups in the past geared towards understanding participant recruitment to research. We held these focus groups, and then we assessed kind of their attitudes about participant recruitment. And then we developed a video that we still use to this day in outreach events to improve recruitment in our studies. Excuse me. So we're hoping to kind of capitalize on this experience with this project and kind of like use it again for this Pepper project. Once the training module is complete, our next step and our final aim is to assess the feasibility of said training module. I plan on hosting new focus groups and then presenting the training module that we developed to the group and give the participants the ability to test out the module itself. This will allow for real-time feedback. This is an iterative process, so we're looking to constantly be improving. What works? What doesn't work? What is, what in the training module did we think made sense, but upon review or upon, a participant looking at it, it actually wasn't clear. This feedback will be important to make sure that we're getting the best training module that utilizes direct patient feedback. Following this, participants will fill out the telehealth usability questionnaire. That's a 21-item questionnaire that you can see a snippet of here that assesses how they feel about the telehealth system and how easy it is to use it. And then finally, participants will be asked to complete 5 realistic tasks to assess performance on health management tasks across 3 typical core functions of a personal health record. So health maintenance activities, these are things like locating an upcoming appointment, lab test result activities, so locating and interpreting a lab result, and then finally medication management activities. So that's, requesting medication refill. Okay, so our first step before we can host our focus groups was to develop the moderator guide that we would use to kind of help guide our focus discussion. We focused on developing our questions across several themes. So first we started off with technology, telehealth, technology and health, and then kind of learning about technology. And we also made sure to develop questions that were specific, whether a participant was in a group that was, the group that was familiar with MyChart or the group that was unfamiliar with MyChart. We wanted to make sure that these questions facilitated conversation. So it was really important that the questions were open-ended and unbiased. A yes or no question doesn't fit in this kind of group because it effectively just ends the conversation. So everything needs to be kind of open. Following the creation of the questions, we had this really unique opportunity to present our questions to the ADRC Community Advisory Board. And this CAB consists of older adults from the community who have an interest in research. They don't kind of want to participate directly, but they kind of like being kind of, the feedback to kind of, our questions. So often we'll present research topics to them or upcoming studies or, any ideas that we have, we present to them and they give us, their feedback. So we were able to present our questions to them on more than one occasion. And then we generated some feedback as well as suggestions for additional questions. And this was quite interesting because, one area of that the CAB felt was important was assessing whether participants in the focus group actually had an understanding of the utility of MyChart, which is something we talked about in the background. So you'd think that we would have thought about this when developing the question. But understanding the utility of technology is an important first step in using technology. This part always makes me think of a patient I had who, earlier on in the pandemic registered to get his COVID shot. He was online at the urgent care. And, someone comes out and says, before that you can get your shot, you need to scan this QR code and register. And he has a flip phone that he lives and breathes by. He loves his flip phone. He has no desire to change his phone. And of course, obviously he couldn't scan a QR code on, that's not something he could do with his phone. So to him, it never occurred to him why he would ever switch phones, because what he uses his phone for, which is for calls, it's exactly what it does. There's no need to change and do anything different. But that kind of highlights the need of, do patients understand the utility of what you're trying to teach them? If they don't, then effectively this is going nowhere. So we had neglected to put that in our questions. So they suggested questions such as, do you know what could be done with MyChart? Do you know how MyChart can improve your health, and kind of ascertaining how they feel about those things. They also felt we should focus our questions on assessing ability and not assuming what someone can do, which again kind of feels like a given, right? We shouldn't be assuming what someone can do. Do you know how to make an appointment? Maybe they know how to log in and check medical results, but they don't know how to email their doctor or request a refill. It's important to assess where the breakdown is in order to better assist participants. Okay, so did I lose a slide? No, I didn't. Okay, so primarily at this point, we have finalized our moderator guide, and we are compiling a list of eligible participants. Via the ADRC, there are participants that come that they engage in our longitudinal cognitive study, and they're not interested in clinical trials, but they are interested in anything that's kind of upcoming. So that is an area that we can pull from. We also have the Martha Stewart Center for Living. It's a geriatric facility nearby that often refer patients to us. So that's kind of an area we're looking for. There are also, kind of a wealth of surrounding areas around Mount Sinai Hospital, including, senior centers that have kind of reached out to us with participants that kind of want to participate in the study. So we're compiling this list. We're going to contact them and kind of offer to, partake in this study and provide the more details about this study specifically. And then we hope to have our focus groups start in the next month. And then we can kind of get going and developing things. And that's that. Thank you very much. And I'm open to questions or feedback.
Thank you very much, Maria. This is great work, and I think a lot of us, how do you optimize use of what could be a potentially wonderful tool for people to engage with their healthcare providers. So we appreciate the challenge. Any questions? Just throwing it up to the group, and feel free to turn your cameras on in the audience if you have any questions.
It looks like Marquita has a question.
Great.
Marquita, you might be muted.
I am. Hello, hello. So Maria, I just have to say that I literally was looking forward to your presentation. No pressure.
That's what my picture was for. It was for strength.
And I love how you came on an hour early, and I think it was just because you felt my excitement. And the reason why I'm so excited is because I am, for my Pepper project, and didn't know anything about you until 2 weeks ago when this announcement came out, I'm actually doing the rural version of what you're doing. So I am doing and developing a rural telehealth navigation tool for rural cancer survivors who have cancer-related distress and anxiety. So literally looking at this and saying, okay, didn't think about that.
Yeah.
I'm calling mine a tool because I'm using an end user design, and I love how you're saying, let's identify the language that folks are using, which is great and something I didn't think about. So I'm using a human-centered design, and I'm calling it a tool. I'm remaining kind of nebulous about it because my participants are actually kind of telling me what they're looking for, right? Mm-hmm. What they need. I think I'm curious. So here's the question. Here's the introduction. Now here's the question. I'm curious, why did you decide on a informational kind of, manual versus any other avenue to kind of engage and educate and address potential knowledge gaps? And it may be, and when I say any other avenue, like basically, why did you go with that versus, maybe saying like, we're going to create synchronous communication and add that here to help, or what came to the information manual decision? Does that make sense?
Yeah, it does. So we're calling it a module because again, I wanted it to be as broad as possible and as open as possible, because I'm really kind of, I'm hypothesizing that these patients can kind of dictate what they want it to look like. So instead of saying, and when I first started this, I did think, oh, a manual, how nifty would that be? You just kind of have this thing next to you that you can look at and, that. And I had some feedback from mentors as well as the Pepper Center themselves that said, like, that's not how everybody learns. Like, even just kind of like looking back and forth, that might be difficult. It's nice to have as a reference, but maybe that's not how people learn, and maybe they need to have someone there for them, or they need to watch something kind of happen, hands-on. So maybe something like a video, or kind of a combination of both, where they can watch the video as much as they want, but also have the manuals kind of they can take notes on, or have it kind of make it their own. So it's gone on a journey, kind of this developing this method has kind of gone on its own journey, and kind of we decided to leave it as open as possible and let patients kind of dictate what they want. And I think that's a really big opportunity, because up until this point, not a single human being has asked the patient what they want with the development of MyChart, right? It's kind of like been developed and then you have to figure it out. So this allows them to dictate what they want and how they want it to look like. And that kind of also allows it for the greatest amount of success, because if it's dictated by what they want, then they'll more likely use it, as opposed to me kind of putting something together and saying, okay, use it.
Absolutely, absolutely. So Maria, again, the kindred spirits situation happening again. So your informational module, basically you're saying is still very open-ended. You haven't kind of, and I was curious if there was if there was literature out there that said that kind of led you in this way, but led you to the informational module. But it seems that your informational module is just as open-ended as my tool, and that we're both trying to kind of identify what do the folks really need, what makes sense for them. And as much as your guidance and your mentors have told you, I personally and my mentors have said the same thing. You don't know what people need. You don't want to be presumptuous and say, hey, we're going to create an app. That may not be the solution. But it is interesting that we're both using open-ended kind of language as we're letting our end users dictate. So that was great. I do appreciate that. And I didn't know if there was something out there that kind of led you towards that language. But it's good to know that you're basically using open-ended language, just like I am, as we're trying to reach back to the folks and say, hey, or not even reach back, but reach out to folks and say, hey, what makes sense to you? So I appreciate
bring
that.
them along for the journey. I think that's the important part, as opposed to kind of bringing them at the end when it's already said and done.
Absolutely, absolutely. And even in my justification, I mentioned over and over again, like, older adults are underheard in this kind of development. They're not heard. And that is problematic, because folks are just working with MyChart, or they're working with their telehealth. And it's just like, you're expected to figure it out. Come as you are and figure it out as you go. So I do appreciate that. All right, I'm going to shut up because I'm gushing inside. But I hope to connect with you offline as well.
Yes, absolutely.
Other questions?
I'll ask about the clinical utility of what clinicians are doing. So I'm a general internist, primary care doctor, and I think I see Cheryl Wilkes on here. We've literally had a meeting this week in our practice about how to cut down on messages, because we are overwhelmed with messages and we can't deal with them. So while I think the goal of engaging older adults in their care, increasing communication at one level is good. The pipes are already full, and part of me is just hearing like more communication, more messaging to primary care practices. It's like there's nobody available on the other end of the line, and we're already like drowning.
Yeah, that's an interesting point that I don't know that I 100% thought of, is that there's like another person on the other end that needs to answer these messages, and they're obviously not available 24/7. But I think what is important is if we can educate older adults on how to use MyChart, then maybe they could answer the questions themselves, as opposed to kind of sending a message and saying, what are my results? They can learn how to look up their results, and it tells them, is it out of is it out of range, or what needs to happen, or they can request a refill without having to contact the doctor directly, right? So I'm hoping that this training can also alleviate a little bit of the stress on the other end, because they can kind of already understand how to navigate the system and answer the questions themselves, kind of putting them in the driver's seat of their own healthcare, as opposed to kind of relying on someone else, whether that be the doctor or their caregiver.
All right, let me,
Great.
Valerie, you put your hand up right as I started launching into my question. So why don't you go ahead?
No, it's okay. Thank you. Maria, a fantastic presentation. When I saw the flyer, I was immediately intrigued. One, because my mother-in-law has Parkinson's and she struggles with MyChart all the time. And, you know, this is an issue that's ongoing. So, you know, just having something developed like this, I think it's really going to be really beneficial for her. But also I'm really into the UX UI design of things. And I really see an opportunity here that you could really introduce the user design and user interface, what you're currently doing. So I'm interested to know, like, how are you using maybe UX UI design to better understand your user and deliver this app that it's like you're saying, you need to understand what your users need in order to implement that. Because I feel like MyChart, someone just created the chart, you know, the app, and it's like, okay, now you learn how to use it. And I think like really understanding, you know, your users, your patients, especially these type of, you know, patients who have mild cognitive impairment would be really beneficial. So I guess what I want to know is like, what kind of questions have you asked your users? Like, what is it, the feedback that you're getting that they really need, and how are you incorporating that to your study?
Yeah, so we haven't started the focus groups yet. So the actual knowledge in terms of what works and what doesn't work, we don't have that quite yet. And I you know, it was a thought that I had, which was it might just be that the interface is just not conducive for a patient population. And that's where I feel like I am limited. I obviously can't redesign MyChart as above and beyond my capability. But what I think could be really important and what could be helpful is if we had this feedback, this is something that we could go to, you know, Sinai or whomever manages this and say, this is what your patient population is saying. Like maybe you want to look into it. And XYZ is really confusing. I mean, they updated MyChart and I am a user and I didn't know what was going on. So I think sometimes patients may think that, and maybe rightfully so, that developers don't want the feedback, but like maybe they do. And if we had a way that it was kind of an organized way where it's like, this is all the feedback that we received, we could present that and that could mean something. I think, you know, these focus groups and getting this feedback has really great implications that could change a lot of things further on down the line, but we're just getting started. So we don't know what those are yet.
Yeah. Cool. Thank you.
You're welcome.
A couple comments that populated in the chat. A question from Anne Marie, Maria is, thank you for the example about the flip phone. What are your thoughts about those patients, the elderly patients who do not have smartphones, so no QR, no apps, etc., and how this impacts their ability to access the benefits of a MyChart type service and access to care?
Yeah, it's a really great question. So it's definitely something that we've talked about even in the development of this project, is that not everybody has access. So we're talking about something that, you know, maybe not everyone has internet access or they don't have computer access, but we're in the process of kind of developing programs even through the ADRC to help provide access for these patients, whether that be through kind of like an internet provided tablet or something to kind of help them provide access. But it's definitely a limitation in that there are older adults that don't utilize the technology. So how can you bring them on board to say, look at this nifty personal health record system that you can use to help you manage your health, when they have no desire to scan a QR code and figure any of that out, right? So it's definitely a limitation that we have acknowledged in the hopes of kind of gaining more participants that can be more involved. We hope to kind of provide these services for them, but it's still kind of in the works and in a lot of different ways and how we're going to figure that out. But a great question.
Yeah. The other question actually, I think, was internally rotated through in a question asked and question answered. So on whether or not there was a geriatrics oversight group for EPIC. Any other questions? Anybody else has a hand up? I know we're coming close to the end of the hour. Just one comment. We do have a design core with our Pepper Center, which is, I think, unique to the Pepper Center network. And I don't know if anybody is from the design core is actually on, was able to make this session, but specifically around healthcare technology and systems design. So trying to kind of find ways to onboard, especially for older adults, you know, with multimorbidity and cognitive issues as well, or just lack of technology literacy. So it might be worth an interest to see if there could be a follow-up to kind of connect and also include Marquita in that mix as well, because these are really important issues. Yeah, I don't see if there's any more hands up.
I have a quick question, Mike.
Sure.
So in response to Jeff, so is Lee on a local committee or is she actually working with EPIC?
My impression is that it's a, but it's probably more geriatrician focused than so-called geriatric patient focused, right? So it's different from what Maria is talking about.
Okay.
But I think, and I forget what they call each of these groups, if it's an advisory group or something, but each of the specialties has an advisory group that EPIC works with.
But I
But
could
is it
certainly
local?
see EPIC really engaging this concept.
Yeah.
I don't think we can just dismiss, like, they won't listen to us. They really do. And then I see Eric Larson on the line. It makes me think too, that we're not just talking about the cognitively impaired geriatric group. Eric, you're working with the cognitively impaired who just had the head trauma from the car accident. So a whole nother group that could be engaged in this.
Right. Not to mention the fact that I think there's a lot of healthy, intact, older adults who probably, Maria, if you were to go ahead and do a full battery on them, there's probably a substantial number who would test above the mean in a lot of cognitive domains who would still go down in flames if they ever tried to get into MyChart. Speaking from personal experience here, I think
Eric, I was going to say, stop talking about my husband.
So it'd be interesting if you brought your neuropsychological expertise to take a look at your cohort, actually do some focus, some actual testing of their ability to look things up and see if people who are still strong and have a capacity to reason through things in any other circumstance just can't make the digital stuff work.
Yeah, that's a great point. And I again, this project can expand and go in so many different directions. And I think you're right. I think the assumption that you present as normal cognitively, that doesn't mean that you are able to use technology in a way that's helpful. I borrowed someone's car, and cars nowadays, brand new ones, oh my goodness, a whole new world. And I myself got in and I said, I don't know what I'm doing. So I definitely understand that. It's a great point.
Seeing no more hands, I think we can wrap up. Thank you very much, Maria. I appreciate you taking the time to meet with us and share what you're doing with your Mount Sinai colleagues.
Yes, thank you so much. It was so fun.
Appreciate it. Happy Friday.
Happy Friday, everyone.
Yes, ma'am.